TeleECHO. Okay, so we're going to get started, but before we proceed, we need to have we need to do some photo op opportunity for we have to write, or I'm writing the annual report for the USDA, and so we need to get some pictures. And one of the pictures I want is of the screen and the Zoom screen. And so if everyone could turn on their cameras so we could see faces, we would really appreciate that. And we need to get rid of that recording. Brenda, can you click? We'll accept the reporting. Happened to us. Okay. So is everyone, just about everyone's on the screen? So Brenda, can you get a picture of that screen? Oh, and Aaron's here too.
Yeah, I got the invite. Wasn't sure if I was supposed to be here or not, so that I jump in and say happy
We're
to
happy,
everybody.
So, get good pictures.
I have one. And let's
Take another one.
one.
Why don't you just take another one for good measure? Okay, that looks good. And did we get pictures in here?
Yes.
Okay, of both from both places. Okay, now we can get back to business. So again, welcome to our TeleECHO session. A reminder that to try and keep your when we aren't sharing slides, to try and keep your faces up there, because it's so great to be able to see you folks instead of just seeing names written there. We do understand that you may have bandwidth problems or something, but it is great to see everybody's picture there. So normally I facilitate this or co-facilitate this with Dr. Doug Patton, but he's unable to be here today. So I'll be running that part of the show on my own. I want to welcome our teledermatology clinic folks first. And so if you are up there, please wave your hand when I say your name. So as you know, or maybe if you're new to us, you don't know that this TeleECHO program is part of this teledermatology program, in which we have a number of rural clinics that are part of this clinical program, where they are using the mole scope and derm engine to look at patients' lesions and so forth and so on. And so that's the backbone of this whole teledermatology program. So if some of our clinic folks, if you're up there, wave your hand. Dr. Sam Whaling from Lee Medical Arts, Lori Hutchins from Mount Vernon, Maisha McFarland from Soperton, Sabrina Watkins from Evans Health and Wellness, Stephanie Cawthorn and Carolyn Jones from Baxley, Floyd Soriano and Phyllis Solomon from Metter, Billy Stott from Sylvania, and John Ferrier from Wadley. So we welcome you to today's session. I want to welcome everyone else. We have residents and some faculty from AU's Department of Family Medicine. We have our dermatologists from AU here. That's Dr. Rabinovitz, Dr. Buchanan. Unfortunately, Dr. Davis is under the weather right now. We have derm residents, we have medical students on board. And then we have other members of the TeleDerm team. So here in our special conference room, we've got Brenda Santiano, we've got Marsal Miranda, we've got Mackenzie Maloney and Gabby Duquesne and Kenza Mamouni, and I'm Rhea Markowitz. So Mackenzie and Gabby are medical students who are involved in the project. So welcome, everyone. So if we can start with the slides. The next slide. I want to offer congratulations. We all want to offer congratulations to Dr. Kush Desai. So Dr. Desai is our clinical liaison for TeleDerm to all the clinics, and he has just been named Campus Assistant Dean for Curriculum at MCG's Southwest Georgia campus. And Kush is one of our own. You know, I honestly, with this appointment, promotion, I don't know if he's doing new things, because he's been doing this, he's been directing the curriculum with Dr. Patton for a while, but he now has this very, very fancy title, and we're very proud to have him on board. As I said, he's one of our own. He graduated MCG in 2016. He did his residency here. And while he was a medical student, he did his clinical training down at the Southwest campus. And he's involved in a lot of rural health. He's the medical director for a CDC-sponsored colorectal cancer screening program down at the Southwest campus. And he was instrumental in establishing the teledermatology program. He's won all sorts of awards. I like in 2021, the Albany Chamber of Commerce Under 40 Young Professional of the Year, and so forth and so on. So we're very, very proud of Dr. Desai and wish him the best. But I hope that these duties don't take him too far away from our project, because we need him. So next is a quick review of what we're going to do today. Following our introduction, Dr. Buchanan will give the didactic portion of pigmented lesions in skin of color. And today's, she's got a lot of case studies to show us today. And then that will go right into another case presentation by Renee Copeland, one of our fourth-year medical students. And that will, Dr. Buchanan will go right into Renee's presentation, and then we will wrap things up and have several announcements and reminders. So on to what's next, which is a little bit of a review for anyone who is not familiar, it may be their first or second time here. This program is part of Project ECHO, which is Extension for Community Healthcare Outcomes, where we move knowledge instead of people. And next, we want to improve. Can we get rid of the participants on the side, because I can't read the slides. Improve knowledge by telemedicine and using distance learning approaches to solve the health disparities that we have here in the state of Georgia. Next. All sessions are recorded, and you're consenting to be recorded. This is an important one to protect patient privacy. Do not mention any PHI in any of our discussions. And you may apply for CME or CNE at the end, and the final slide will have the number, and the chat will it will also be in the chat. If you have any questions, you can always email us at any time to teledermatology@augusta.edu. And Project ECHO collects certain data that is always kept confidential, but is used for various purposes. And then the usual Zoom reminders, keep yourself muted when you're not speaking, but do unmute yourself when you go to speak. You can type questions or so forth in the chat. You can use the electronic hand. As I mentioned before, please use your camera and have your screen on gallery view so we can all see each other. And if you have technical problems, you can email Kenza at the email address below. But of course, we're all such experts at this now that we don't have any more problems. So next, that brings us into our didactic program. So I am happy to introduce Dr. Kendall Buchanan, one of our dermatologists. She practices at AU's Care Center for Dermatology in Aiken, South Carolina. And she is going to talk about a subject that has come up, which is pigmented lesions in skin of color. So take it away.
All right, we'll go ahead and get started. I have about 8 cases to review. Just keep in mind that some of these concepts are very difficult, so I'm going to try to present it very clearly, but we will have to take other lectures to sort of devote to some of these topics, such as nails and acral lesions. So I'm going to do this through case-based presentation. Okay, so our first case, this was a 61-year-old African-American female, and she presented to the dermatology clinic for a full skin check. She basically we noticed this spot on her right foot, no family or personal history of skin cancer. When we look with dermoscopy, we see certain features. We see few colors, light brown, dark brown, and gray. It's symmetric in pattern and shape, and we see that it's overall organized. What I want to point out here that's key in acral lesions is recognition of the ridges and the furrows. So the furrows are these lines that you see, and then the ridges are these thicker brown areas. And then you also see sweat glands, which are these eccrine ducts that are located on the palms and the soles. And so this is called a parallel furrow pattern. So when we talk about the palms and the soles, we think about this in terms of our fingerprints, and this is formed by the parallel ridges and the furrows. And we know that the eccrine duct or the sweat gland is going to transverse the epidermis through the ridges. And so this is an example of acral skin that's been highlighted with a marking pen, and you can see the furrows, which we often call the valleys or the sulci, and then the ridges referred to as the mountains. And so here's an example. Here you see the furrows, and those are the valleys, and the ridges, which are the mountains, and the circles are the sweat glands that you see. Again, just to kind of make sure we understand this concept. So the mountains are always larger than the furrows or the valleys. Okay. Sorry, okay. And then the eccrine duct meets the surface at the top of the ridge. Okay. Recognition of this is critical because NEVUS cells are predominantly found in the furrows, which creates that parallel furrow pattern. And atypical melanocytes are predominantly found in the ridges. And this is a schematic that highlights that. You see NEVUS cells here in the furrows, and then atypical melanocytes here in the ridges. And so if we look at our case again, you do see some pigmentation in the ridges. That's not uncommon in darker skin types. This is most likely a compound melanocytic neoplasm. But the teaching point here is that the parallel furrow pattern is very uncommon in melanoma, and if seen, it is usually focal. And this is an example of a parallel furrow pattern in a Fitzpatrick 1 skin type versus a Fitzpatrick 4 skin type, just for comparison. There's other patterns that we can see on acral surfaces, which include the lattice-like pattern and the fibular pattern. There's also many different patterns within the parallel furrow pattern. So you can have a single line variant, a single dotted line variant, double line variant, and a double dotted line variant. And these are all benign patterns. The lattice-like pattern is a variation of the parallel furrow pattern. So you see the pigmentation of the furrows here, and then these crossing parallel lines that make it look like a ladder. Another example here. Again, you see the furrows and then the red arrows, which are the ridges, and you see pigmentation that follows and crosses the furrows. So this is a benign pattern called the lattice-like pattern. This is another example in an Indian female who was seen in our pigmented lesion clinic. This was a lattice-like pattern. The fibular pattern, this one's a little bit harder to, I think, kind of conceptualize, but it's dense fibular pigmentation, so slanted lines, which consists of multiple thin parallel lines that does not have respect to the ridges and furrows. So this is an example of a fibular pattern on a patient's heel. Similar example here. And then what's interesting about these patterns, this was a study in the JAD in 2005. They noticed that these types of different patterns were more prevalent depending on what area of the sole. So we tend to see the fibular pattern more commonly on the weight-bearing areas, which is highlighted here in blue. The parallel furrow pattern more so on the edges of these areas, and then the lattice-like pattern more commonly seen on the arch. So just keep that in mind as you're evaluating pigmented lesions. Now, when it comes to melanoma, the most common pattern that we will see is the parallel ridge pattern. You can also see other features, especially if it's a more aggressive or invasive melanoma, and this includes an abrupt cutoff, irregular diffuse pigmentation, multiple colors, blotches, atypical black dots and globules, streaks, and blue-gray areas. So here's an example here of a melanoma on this patient's foot. You can see this irregular diffuse pigmentation. You see multiple colors of blue, brown, black, and gray. You don't really need dermoscopy for this, given how irregular this lesion is. But you also do see some atypical dots with dermoscopy. So this was a malignant melanoma. Now, when we talk about the parallel ridge pattern, you guys now know what the valley and the mountains are. So again, the furrows and the ridge. So this parallel ridge pattern is pigmentation that's aligned along the ridges. And this can be seen in both melanoma in situ as well as early invasive melanoma. And as we know, we can see melanoma in skin of color. And so here you have your ridges and your furrows, and you see the pigmentation is confined to the ridges. So this is seen with a melanoma. Here again, your furrows and your ridges, the parallel ridge pattern. Another example of a large irregular pigmented lesion on the bottom of this patient's foot. You can see it also has other features, which include irregular diffuse pigmentation, multiple colors, blotches, and then again, you see that parallel ridge pattern along with atypical dots and globules in acral melanoma. A few more examples here. Again, the teaching point being recognition of the parallel ridge pattern. There are other patterns that you can see in melanoma, but the teaching point here is that recognizing the parallel ridge pattern is key for a diagnosis of acral melanoma. And I just want to point this out. I think I reviewed this in my melanoma lecture, but we do know that overall, acral and mucosal melanomas are more common in skin of color, and they can be more aggressive. Overall, we know that there's decreased survival in skin of color, partly because of advanced stage at diagnosis, longer time from diagnosis to surgery, as well as racial disparities. Okay, our second case. A little bit easier with this one, and you guys have seen this case before, but this is a 46-year-old male, African-American. He was coming in for a routine skin check, no history of skin cancer, but he did have this area on his lower left leg that he was concerned about. So this is another way to kind of look at our algorithm. So off the bat, what I saw with dermoscopy was a network with a central white blotch. And here we can point out this peripheral delicate network. There's also some areas that appear to be like circles or rings. And then you see this central scar-like area with multiple shiny white lines. There are a few colors, light brown, dark brown, white, and gray, and it's symmetric in pattern and shape and overall organized. So this is an example of a dermatofibroma. And what you see here is the network with central white scar-like area. Remember that whenever we see these shiny white structures, we know that that corresponds to altered collagen and fibrosis, which are seen in dermatofibromas. This is a comparison of a dermatofibroma and a Fitzpatrick skin type 2. So you can see how this redness or pinkness is a lot more prominent. That won't always be the case with dermatofibromas, but you will rarely see this kind of light pink or red pigmentation in skin of color. So again, this is a dermatofibroma. Usually when you see one dermatofibroma, you can see others. This is not the only type of pattern of dermatofibromas you can see in skin of color. Sometimes they will simply be just a diffuse, homogeneous brown or black color, but this is one example here. Our third case, so this was a 69-year-old Hispanic male coming in for a routine skin check. He has a history of a pigmented basal cell that was on his chest. He came in and he had his isolated dark papule on the left cheek. So when looking at this, we have to have a differential. The differential is truly the most important. So when we're thinking about pigmented facial lesions, we think about, is it a nevus, a melanoma, a pigmented actinic keratosis, lichen planus-like keratosis, solar lentigo, or seborrheic keratosis. And then we use dermoscopy to help refine that differential. So it's going to be one of two. It's either going to be benign or malignant. And for malignant, we really want to recognize the melanoma simulators, which include a pigmented AK, pigmented BCC, and lichen planus-like keratosis. On the left is a lichen planus-like keratosis, which is benign. It's usually a regression of a solar lentigo or a seborrheic keratosis. And on the right, you see a melanoma in situ. These would be very hard to tell the difference clinically. So we use dermoscopy to highlight certain features. The features that you see with facial melanoma are slightly different than melanoma that we see in areas of chronic sun damage or on the trunk and extremities. So these are the features that we see. So slate gray to blue gray dots and granules, irregular gray-brown pigmentation between follicles, angulated lines and rhomboidal structures, gray follicular openings, dark structureless areas that obscure the follicular openings, circles within circles, white shiny structures, and blue-white veil. So when we look at our case, we see a slight area of scale. We see these prominent follicles, or what we sometimes call evident follicles. And we see these diffuse gray dots granules, which we sometimes call peppering. There's a few different colors, light brown, dark brown, white, gray. It's overall fairly asymmetric in pattern and shape and disorganized. Now, the features that we see that could indicate a facial melanoma, as we talked about, include those slate gray to blue dots and granules. So we did a shave biopsy, and what we want to point out is that there was a fine scale to the surface, and there were not only diffuse gray dots granules following an annular distribution. Whenever you see that, you think more of a lichen planus-like keratosis. So a shave biopsy demonstrated this pre-malignant dyskeratosis with increased melanin in the basal cell layer, no evidence of invasion, and then you can see this background of chronic sun damage. So this was consistent with a pigmented actinic keratosis. So you can see actinic keratosis in skin of color. Notably, they will often be pigmented. So keep the pigmented actinic keratosis in mind whenever you have an isolated lesion on the cheek. Our fourth case This was a 4-year-old Asian male. This patient was seen in our pigmented lesion clinic. He presented with this dark band that was present on the nail of his right fourth finger, and his parents were rightfully concerned. So whenever we think about nails, we need to look at the following morphologic features. So you want to evaluate the cuticle area, you want to evaluate the hyponychium, and you want to evaluate the band, and that includes the spacing and parallelism. So nail pigmentation, you can think about it two different ways. So you can think about, is the pigmentation melanin? So is it melanocytic or non-melanocytic, or is it due to something else? So non-melanin. So non-melanin, this is just an example of what you might see. This is a fungal infection. You can see these yellow to yellow brown inclusions. So this was a dermatophyte or fungal infection. And then another example, I actually had a case this week of a patient with a history of melanoma. She came in concerned. She didn't remember any trauma to her nail. But you can see here with dermoscopy, we see these round circular blood spots at the proximal end. And then at the distal end, you see this purple pigmentation with a filamentous pattern. So this is an example of a subungual hematoma. Most of the time, the patients will remember like dropping something on their toe or something like that, smashing their finger, but occasionally they don't. And it's our job to provide reassurance. And this is just another example here, round circular spots at the proximal end. And then you see this purple pigmentation with a filamentous pattern at the distal end, okay? Now, when we talk about melanin, we're talking about diffuse longitudinal pigmentation arising from the nail matrix. Okay, so this is just a schematic of what the nail looks like. And so we know that when melanocytes, they reside in the matrix, and when activated, they form this band of pigment that extends from the nail matrix to the free edge. Okay. So there's lots of different kind of charts and algorithms you can go through. We already talked about this. If it's not melanin, then what is it? So keep in mind your differential of subungual hematoma. You can have green nail syndrome. That's usually due to Pseudomonas or dermatophyte infection. Okay, so and you also need to focus on if the pigmentation involves a single digit or one or more digits. So with dermoscopy, the first step is we want to ask ourselves, are the lines gray or brown? So first we're going to talk about these gray lines. So with a lentigo, these lines tend to be gray. So this is an example of a nail apparatus lentigo. You see these gray homogeneous longitudinal bands between the short arrows, and then you see these thin overlying longitudinal lines. Another example here of a lentigo, again, those gray homogeneous longitudinal bands with these thin overlying longitudinal lines. Other times you can see gray are due to ethnic pigmentation. Now, this is an example. I see this a lot. So typically ethnic pigmentation, you will have multiple nails affected. Most of the time, the lines can either be brown or dark gray. And so here's an example with dermoscopy. You see these gray homogeneous longitudinal bands in between the short arrows. And like I said, sometimes multiple nails may be affected. You can also see multiple nails affected if there's a drug-induced cause as well. Now, if the lines are brown, this is when we really want to take a look at the band pattern. So is it regular or irregular? So if we think about regular, this is an example of regularly spaced, homogeneous brown linear bands. So this is a NEVUS of the nail matrix. These bands are more irregular. They're different sizes and shades. And this is an example of a melanoma in situ. When you talk about regular brown bands, they tend to have parallel lines, a regular pattern, homogeneous color with regular spacing and thickness. Another example of a nail matrix melanocytic nevus, you see that these are thin regular lines that are regular in thickness, color, and spacing. Another example of a nevus in a darker skin type. You see, again, the lines are darker, but they're parallel. You see that background brown coloration, and you see that they're regular in thickness, color, and spacing. Now, irregular lines, we're going to be more concerned for a malignant lesion. So is there disruption of the parallelism? Are there multiple colors, irregular spacing, and thickness? So this is an example of a nail matrix melanoma. So brown coloration of the background with an irregular pattern of lines in their thickness, color, and spacing. Another example here. You can see these multiple irregular lines that are different thickness. And this one's more so obvious. This one you see a positive Hutchinson sign, which is nail pigmentation, pigmentation outside of the nail. You usually see it here at the proximal nail fold. So back to our case. So we know that this is melanocytic, and we know that we have brown lines. And so they appear to be regular. This is our dermoscopy photo. Again, you see that brown coloration of the background, thin regular lines in thickness, color, and spacing, and the lines are parallel. So we're actually going to have this patient come back in a few months, but generally you do periodic observation if you see a nevus like this in childhood. So I think we're checking his nail back in about 3 to 4 months. Our fifth case, don't worry, they're going to get easier. 84-year-old Asian male, he had this dark papule on his left neck getting darker, no history of skin cancer. So we've talked about these features before. We see these sharp, well-demarcated borders, we see fissures, we see comedo-like openings, we see ridges. And so these are all features of seborrheic keratosis. They don't tend to be much different in skin of color than Fitzpatrick's 1 or 2. The lesion can overall be darker, but as you can see, they have multiple features like comedo-like openings, fissures, sharp demarcation, and ridges. So this is an example of a seborrheic keratosis in an Asian male. And then this is a Fitzpatrick's 5 male. He came in with this pigmented lesion on his left thigh. You can see the sharp borders, the fissures, the ridges, and this was also a seborrheic keratosis. Case number 6, an 84-year-old Asian male. He reports he has multiple barnacles. So he had several that were seen here that were consistent with benign keratosis, but then he had this one darker mole that was located on his abdomen. When we use dermoscopy, we see a peripheral network that fades into the periphery, and we see this central blotch or hyperpigmented area. If you remember from one of our earlier lectures, we talked about benign nevus patterns, and this pattern is consistent with peripheral network and central hyperpigmentation. And so remember that skin phenotype influences nevus patterns. So you recall in a type 1 patient, we often see that peripheral reticular network with central hypopigmentation. And the darker the skin, we can see more of the pattern that we saw in this case, which was the peripheral reticular network with central hyperpigmentation. So again, just for comparison, now not all nevi in a Fitzpatrick 1 patient are going to have this pattern, but this is just an example of how we can have different patterns depending on our skin phenotype. And so again, this is a benign melanocytic nevus. This was a 67-year-old Latina female. She had this enlarging blue-black lesion on the left upper back. She also has a history of melanoma in situ of her right lower leg. So on dermoscopy, we see these beautiful leaf-like areas, this blue-gray ovoid nest, and we see these interesting looking vessels that are what I call twisted loop vessels. So these are all features that we see with basal cell carcinoma. We see the leaf-like areas, the blue-gray ovoid nests. Twisted loop vessels aren't as common, but they can be seen with basal cell. And when biopsied, we see these nodular basaloid tumor islands, and you see all this pigment that's in the tumor islands that consists of melanin and melanophages. And then you see this tumor stroma that also has melanophages. And so this was consistent with a pigmented nodular basal cell carcinoma, which we will see in skin of color. I actually had a case sent to me today that appeared to be a pigmented nodular basal cell on the cheek of a Hispanic male. So, and this is another example here. This Hispanic female, she had this new spot with a small erosion on her left temple. What we see here, I think these are leaf-like areas, but then you also see these blue ovoid nests right here. And then when biopsied, you see your basaloid tumor islands with multiple pigmented melanophages. And again, you can see this sort of peripheral palisading here, which is consistent with a basal cell. This last case, this is not a pigmented lesion, but I thought it was important to kind of talk about in skin of color. This was an African-American male. So he has a history of discoid lupus. And what you see here is this pink-white plaque that developed in an area of scarring on his upper lip. So when we look at this with dermoscopy, we see this area of scale crust. We see these white circular or ovoid structures. I imagine that sometimes it's hard to take dermoscopy photos when something has a lot of blood vessels, because as soon as you put your dermatoscope on it, it can blanch the blood vessels. But I imagine there was multiple like vessels as dots or perhaps coiled vessels that we could also have seen. And so these are patterns that we see with squamous cell. We see white circles, we see scale crust. And so this is a keratin pearl that was seen on biopsy. And so this was consistent with squamous cell carcinoma that's arising in chronic cutaneous lupus or discoid lupus. And so as you recall, one of the risk factors for squamous cell carcinoma in skin of color is chronic inflammation, which we can see with discoid lupus. From what I've read, it generally takes, somewhere around 15 years is the average time for development of a squamous cell in an area of scarring for discoid lupus. And the lower lip does tend to be a more common site for this to develop. And I think that's it. I really enjoyed presenting this topic, and we will certainly need to dive deeper into some of these topics, because this lecture was challenging with us talking about acral, facial, and nails. So without further ado, I would like to introduce Renee Copeland. She's a very bright fourth-year medical student who's currently applying for her dermatology residency, and she is going to present a case of another pigmented facial lesion. Sorry, trying to stop okay.
Hello, everyone. I'm Renee Copeland. I'm a fourth-year medical student, and today I will be presenting on a pigmented lesion in a skin of color patient. So a 54-year-old female presented to clinic and she's
Hey, Renee, sorry to interrupt you. Can you share your screen?
Yes. Are you able to see the screen now? Okay, I'll start over. So today I'll be presenting on a pigmented lesion in skin of color. And so a 54-year-old female presented to clinic. Her skin type was Fitzpatrick 4, and she had a lesion of concern on her right cheek. It's been present for 1 year. She says it's enlarged in size and describes it as itchy. She's used many topical creams without any improvement. and she has no history of skin cancer. However, her mother does have a history of skin cancer, and she has no history of connective tissue disease. On physical exam, her right cheek has a light brown patch with some overlying scale. On dermoscopy, we see some gray follicular openings, as well as gray dots and granules in an annular distribution and some fine scale. The colors that are present are tan with some slight erythema superiorly, and it's symmetric in shape. However, there's some asymmetry in its pattern. And just to review the slide that Dr. Buchanan went over in her presentation, there are certain classic features that you see in facial melanoma on sun damaged skin that you don't see elsewhere on the body. Typically, you don't see the characteristic pigment network that you would see in other melanomas on the body. And in our patient, we see that she has slate gray to blue gray dots and granules, which are present in 92% of facial melanomas, and then the gray follicular openings as well. And just to step through the dermoscopic features that are present, we ask, are there any classic features associated with facial melanoma on sun damaged skin? And yes, she has the gray follicular openings and the gray dots and granules in an annular distribution. Is there scale? Yes, there is. And scale is present in something is likely not present in a melanoma and more present in a benign lesion. And then finally, are there only diffuse coarse gray dots and granules? And the gray dots and granules are not diffuse in this lesion, which is a little bit more concerning for melanoma as well, whereas a benign lesion, it would be more diffuse. So the differential diagnosis here is a more malignant lesion, which would be a melanoma, and given the peppering that we see on dermoscopy, that is very well could be the case. But we also can consider more benign lesions, such as a lichen planus-like keratosis, and this is a regressing seborrheic keratosis or solar lentigo. And there's different stages that they present, but in certain stages they can present similarly to a melanoma. And then finally, we don't want to rule out a pigmented actinic keratosis, which is also a benign lesion. And given the scale that is present, we don't want to rule that out either. So given the concern for melanoma, we biopsied it, and you can see that there is a vacuolar interface dermatitis, which is consistent with some inflammatory process. And when you zoom in, you can see perivascular and periadnexal infiltrate, and no eosinophils. And then you also can appreciate the vacuolar interface dermatitis as well. And then you have a lichenoid band-like inflammation. And so on pathology, it's actually more consistent with cutaneous lupus given the inflammatory process and less likely a benign lichenoid keratosis, but it still could be that. So when we look at it clinically, we see that in dermoscopy findings in cutaneous lupus, you typically see dotted linear and linear branched vessels on a pink red background. And I did some research on what this looks like in skin of color patients as well. And you still see the erythema that is present in this patient that we see in the presentation. And so with that information, given that the patient did not have this background erythema, we thought that it was likely still a lichen planus-like keratosis. And also, the patient underwent autoantibody testing and her ANA was negative, but it is possible that she may develop a cutaneous lupus down the road. So we would continue to monitor for any additional new lesions. So just to review, lichen planus-like keratosis is an inflammatory response of a regressing solar lentigo or seborrheic keratosis, and it can develop or it can regress over a period of 3 to 8 months. As you can see in this picture, it starts off as more of an erythematous, scaly papule or plaque, and then it slowly has peppering on dermoscopy. And so this is why it gets its name, the great mimicker, where it can mimic melanoma or pigmented basal cell carcinoma, and those are diagnoses that you wouldn't want to miss. However, we do see on dermoscopy that it is often associated with coarse granules in lichen planus-like keratosis versus in melanoma, you'll see fine granules. So really the key takeaway from this case is to identify differences in melanoma versus benign lesions in a patient that is presenting with an isolated pigmented lesion on the face. And I'd just like to thank Dr. Buchanan for this case, and that is it.
Thank you, Renee. That was great. And another thing Renee and I had talked about was just, you know, we get focused on dermoscopy, and so we, you know, sometimes we do need to take a step back and say, could this be anything else? You know, in our case, I thought it was very interesting. I've had multiple conversations with our pathologist, and like Renee mentioned, we did, you know, tests for ANA. And so we're going to see this patient back in a few months and just continue to monitor. But, you know, don't forget about things like lupus or fixed drug, other things that can sort of mimic a pigmented lesion.
Are there any other questions? We saw a lot of different cases today. So does anyone have questions for either Dr. Buchanan or Renee?
I would just like to make a comment. It's very, very well done. Regarding melanomas, particularly with individuals with Fitzpatrick 5 and 6 skin, the most common melanomas in individuals with Fitzpatrick 5 and 6 skin are acral melanomas. And it's important to, when you're seeing patients in the clinics, to be aware of the fact that it's really critical to look at the bottom of their feet. In Mexico, the number one type of melanoma is acral lentiginous melanoma, and it occurs in about 48% of all of the melanomas that we're seeing in Mexico over a multi-year period. So it's really, really critical to look at the bottom of the feet. Melanomas are very subtle when they're early, and a very important clue is the clue that Dr. Buchanan commented on, which is the parallel ridge pattern.
Any other comments, questions?
For the melanoma of the fingernail, do those present very suddenly or do they grow slowly from the cuticle? What's their like gradual presentation?
So they present as a linear band, and that's called melonychia. And usually we look at clinically, it's very, very difficult to distinguish whether it's benign or malignant. And that's why dermoscopy is so important for those types of lesions. But it takes a considerable period of time, approximately 6 months, for you to develop a complete band. Now, regarding the young boy, the 4-year-old, there are maybe 4 or 5 cases in the world's literature of melonychia melanomas in young children. And the overwhelming, almost all of these are congenital nevi. So it's extremely uncommon to have a melanoma in a child of this age.
Okay, well, I would like to thank Dr. Buchanan for such an extensive presentation, and Renee and Dr. Rabinovitz for his for all of his comments. Brenda, can I have the slides back? I wanted, before we leave, I want to remind you about some of the resources that we have on our TeleDermatology in rural Georgia website. So the center, the center illustration is the main webpage, and we have a number of training videos that are geared for healthcare healthcare providers. We have about 8 or 9 of them, and you can watch them and You can also take them for CME or CNE credit, depending on which button you push. So that's a really good resource for you. We also have on that page some manuscripts and guidelines of care. And on the community page of the website, we have a number of PowerPoint presentations that are geared to your patients. So for those of you in our teledermatology rural clinics, we've sent you flyers and bookmarks to give out to your patients. I want you to, I hope that you will inform your patients at the clinic about these options. And then I also want to point out that we now have all the past TeleECHO conferences that we've had. The recordings from those are now posted again on the healthcare provider webpage. So these are all great resources for you. Also, a reminder to the healthcare providers in our rural clinics, when you do a consult, a reminder to fill out that patient information form and send it back. You upload it into Derm Engine, and we need you to do that within 24 hours of your sending in the consult. So next slide. Our next session will be Monday, February 6th. Dr. Buchanan will talk about facial lesions. Oops, we lost the slide. And we'll have one case presentation by Omkar Mayor, one of our medical students, and we are looking for someone to do the other case presentation. Hopefully one of our clinic healthcare providers, or if there's someone else out there who would like to do one, please let us know at teledermatology@augusta.edu. And the CME code is 9102, and you text that to the number there, and it's also posted in the chat. So unless there are any questions or comments, I think that
I just wanted to say one quick thing, Rhea.
yeah, sure.
Sorry, guys. I forgot to mention, when you're looking at nails, you want to use some sort of gel. So ultrasound gel, or occasionally if I haven't had any, I'll use the gel hand sanitizer. But it's a lot easier to see using your dermatoscope if you have some sort of gel.
Okay, very important. We know that. Okay, so unless there's anything else, I think that all of our guests and our healthcare providers can sign off with a reminder to that our TeleDerm team stay on for a couple minutes for a debriefing. So thank you very much, and we'll see you in a month, February 6th. Thanks a lot. So you're saving the chat. Yep. Okay. So